Hi, how are you? Hi, my friends. It's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. Assalamu alaikum for everybody. The Islamic greetings for everybody. Uh, Anywhere the people are listening this video in the morning, so good morning for you. And if somebody is listening in the evening, so good evening, everybody. So my topic is today is very important topic, not surgically. I'm a neurosurgeon, but definitely this patient need the proper neurosurgical attention or neuroscience department involved in this topic. What I am the topic they want to discuss in front of you. The topic is that the cavernous sinus thrombosis, and I know that as you heard that name, definitely you will understand that what kind of topic is that, and I wanted to try to explain in detail and wanted to try some ambiguities if there are. I want to clarify for you as well simultaneously. The cavernous sinus thrombosis is a rare life-threatening disorder that can complicate the facial infection and sinusitis, or you can say the orbital cellulitis, pharyngitis, or otitis, or following traumatic injuries or surgery. So especially in the setting of the thrombophilic disorder, this can happen. And early recognition of the cavernous sinus thrombosis, which often present with the fever, headache, and eye findings such as the periorbital swelling and the ophthalmoplegia, is the criteria and it is critical for the good outcome. So early recognition is a very prime thing for the cavernous sinus thrombosis, which often present with the fever, headache, eye findings such as the periorbital swelling, and ophthalmoplegia is a critical for the good outcome. Despite the modern treatment with antibiotics and anticoagulants, the risk of the long-term sequelae such as the visions, diplopia, and stroke remains significant. So this activity examine when cavernous sinus thrombosis should be considered, how to properly evaluate this condition, and the role of the interprofessional team in caring for the patient with this condition is very important. The objective of this lecture, actually, I wanted to present in front of you. I wanted that I should clear, or we can review the causes of the cavernous sinus thrombosis, and I could describe the presentation of the patient with cavernous sinus thrombosis, outline the treatment option for the cavernous sinus thrombosis, and I wanted to explain when cavernous sinus thrombosis should be considered, how to properly evaluate this condition, and the role of the interprofessional team in caring for the patient with this condition. So, I want to introduce bit of the cavernous sinus thrombosis like that. Cavernous sinus thrombosis is a rare life-threatening disorder that can complicate facial infection or sinusitis or orbital cellulitis or pharyngitis or otitis or following traumatic injury or surgery, especially in the setting of the thrombophilic disorder, and the early recognition of the cavernous sinus thrombosis, which often present with the fever, headache, eye findings such as the periorbital swelling and the ophthalmoplegia. It's critical for the good outcome, and despite the modern treatment with antibiotics and the anticoagulation, the risk of the long-term sequelae such as vision, diplopia, and the strokes remains significant. So now, as you know, The etiology of the patient, the cavernous sinus thrombosis is usually septic but can also be aseptic. And septic cases can follow central facial infection, especially within the danger triangle of the face from the corner of the mouth to the bridge of the nose. And these includes abscess or cellulitis, sinusitis, especially spondylitis and etomoditis. So this is very important. You should know that cavernous sinus thrombosis usually septic. It is really septic issue, and sometimes it behave like aseptic. So this is the thing we have to understand. Actually, this is a septic issue, septic thing, but it can behave like a aseptic. And this septic case can follow central facial infection, especially within the danger triangle of the face from the corners of the mouth to the bridge of the nose. This triangle will become here like that, the corner of the mouth and the bridge of the nose. So you can appreciate, if I remove my glasses, you can appreciate this triangle. I think it is very clear for you. So here, as I mentioned, these include the abscess, so I was just explaining that the dental infection, extraction, dental extraction, or the procedure related to that, even a posterior superior alveolar nerve block entering the pterygoid plexus, it is also nasty cause of the, or may cause the cavernous sinus thrombosis. Maxillofacial surgeries, otitis media, mastoiditis, aseptic causes are less common than the septic causes. So these include the trauma, surgery, pregnancy, and like these. So in that regard, that a variety of the infectious organism can cause cavernous sinus thrombosis, although the majority are the bacterial. And bacterial Staphylococcus aureus may account for 2/3 of the cases, and the methicillin resistance should be considered. Other typical organisms include Streptococcus species, approximately 20% of the cases, and Pneumococcus, and a gram-negative species such as the Proteus, such as the Haemophilus influenza, such as the Pseudomonas, and the Fusobacteriums, bacteroids, and as well as gram-positive species such as Corynebacterium and Acinitomyces. So several of these bacteroids, actinomyces, Fusobacteriums are anaerobic. So the fungal infection in cavernous sinus thrombosis is less common but can include aspergillosis. But the fungal infection in cavernous sinus thrombosis are less common but little different. And aspergilloma or aspergillosis is the most common fungal infectious element, like a zygomycosis, such as mucormycosis or a coccidomycosis. All will happen especially in the immunocompromised individuals. And the rare participant of cavernous sinus thrombosis can include parasites such as toxoplasmosis, such as malaria, trichinosis, as well as the viral causes such as the herpes simplex virus, cytomegalovirus, measles, hepatitis, and human immune deficiency virus. Can be the cause of the cavernous sinus thrombosis. Immunosuppression, such as the uncontrolled diabetes, steroid use, cancer, chemotherapy, may be risk for not only developing the cavernous sinus thrombosis but also developing complications. Here, the biggest risk factors are the facial infection, acute sinusitis, periorbital infection, thrombophilia is a significant risk factor for the cavernous sinus thrombosis. Women who are pregnant, postpartum, or receiving oral contraceptive pills or hormone replacement therapies, maybe they have a chance or increased risk of the cavernous sinus thrombosis. A variety of thrombophilic genetic disorder may lead to the cavernous sinus thrombosis. These include factor V Leiden mutation or prothrombin, for example, G202110A mutations, all antithrombin and 3 protein C or protein S deficiencies may cause the cavernous sinus thrombosis. Increased factor of 8, it may cause the cavernous sinus thrombosis. So acquired disorders such as the antiphospholipid antibodies syndrome, or we can say antiphospholipid antibody syndrome, or the hyper homocystinuria or hyper homocystinuria, also the cause of the cavernous sinus thrombosis. Increased factor 8, heparin-induced thrombocytopenia and obesity should also contribute to cavernous sinus thrombosis risk. Other risk factors for the thrombosis include severe dehydration, such as in the hyperosmolar non-ketotic state, nephrotic syndrome, sickle cell disease. All are the factors for this. What we say, this is the hyperketosis. This all may cause the cavernous sinus thrombosis. So, severe dehydration, simple thing, but it can cause the cavernous sinus thrombosis. So, plenty of the factors can affect the cavernous sinus thrombosis, but epidemiology, cavernous sinus thrombosis is so rare that includes I want to discuss with you a lot of factors such as for this problem, such as this patient, what are the etiology? Etiology is huge etiology. So a lot of things you can say a name for the cavernous sinus thrombosis. But the cavernous sinus thrombosis, little epidemiology I want to present in front of you is the rare that incidence data is difficult to estimate. So the cavernous sinus thrombosis comprises approximately 1 to 4% of the cerebral venous and sinus thrombosis, and which has an annual incidence of approximately 2 to 4 per million people per year. 2 to 4 per million people per year. It is good that percentage should be less. With higher incidence in children, one can estimate that the annual incidence of the cavernous sinus thrombosis might be approximately 0.2 to 1.6 per 100,000 per year. And a male or female predominance in cavernous sinus thrombosis is uncertain up till now, despite a 3:1 ratio of the female predominance in cerebral venous thrombosis. Thus may not be case of the cavernous sinus thrombosis. In that regard, so you can say the female are more predisposed with that problem at some extent, but it's still it's different area to area, but the estimation usually like this. Historically, cerebral venous thrombosis has been reported to be more common in children and neonates than in adults, although the effect of the routine vaccination and frequent use of antibiotics, such as for the otitis, on this relationship are uncertain. The incidence and the mortality may be decreased likely due to the availability and the use of the antibiotics. That's why I am telling that this disease is a septic disease, sometimes present like aseptic. And a lot of etiology I told you, which not caused by the septic issue, but non-septic, but are there. I want to discuss with you little pathophysiology of this cavernous sinus thrombosis. Cavernous sinus, one on each side of the sella turcica. You know that above and lateral to the sphenoid sinus, anterior and superior orbital fissure, and posteriorly petrous part of the temporal bone are trabeculated cavernous sinus space created by the layer of the dura mater and filled with the venous blood. And this blood drains the superior and inferior ophthalmic vein and superficial cortical vein anteriorly, and then drain into the basilar plexus posteriorly via the superior and inferior petrosal sinuses. The cavernous sinus has been coined the anatomic jewel box because it shares an intimate relationship with several important structures within the lumen of the cavernous sinus past the horizontal segment of the internal carotid artery. The sympathetic plexus and the cranial nerve, such as the cranial nerve number 6, abducens nerve, is medially. So within the lumen of the cavernous sinus passes the horizontal segment of the internal carotid artery. It is very, very important part. And the sympathetic plexus and then the cranial nerve, which is the sixth cranial nerve, which the name is the abducens nerve, and which is medially to it. Whereas the outer layer of the lateral wall of the carotid sinus are traversed by the cranial nerve 3 oculomotor nerve and cranial nerve 5, the first and the second branch, such as the ophthalmic and the maxillary branches of the trigeminal nerve, and the fourth cranial nerve, which is the trochlear nerve. Septic cavernous sinus thrombosis occur from the following things, such as local spread, often from the valveless, facial and ophthalmic vein, adjacent infection such as the sinusitis, posteriorly possibly, and the most common cause especially sphenoiditis and the etymoiditis. In the same manner, the facial cellulitis and abscess, especially within the danger triangle of the face formed by the corner of the mouth and the bridge of the nose. Periorbital and the orbital cellulitis, pharyngitis, tonsillitis, otitis media, mastoiditis, dental infection. These all are causing septic cavernous sinus thrombosis. I named in detail in front of you. In the same manner, the mechanism is due to the embolization of the bacteria and other infectious organisms which trigger thrombosis, which then can trap infection within the cavernous sinus. Cavernous sinus thrombosis lead to decreased drainage from the facial vein and the superior and inferior ophthalmic vein, resulting in facial and periorbital edema, ptosis, proptosis, chemosis, discomfort and pain with eye muscle movement, papilledema, retinal venous distension, and loss of vision. So these all can be caused by the cavernous sinus thrombosis. That's why I am telling cavernous sinus thrombosis lead to a decreased drainage from the facial vein and the superior and inferior ophthalmic vein, and resulting in facial and periorbital edema, ptosis, proptosis, chemosis, discomfort, and pain within the eye muscle movement and papillary edema, retinal venous distension, and loss of vision. Lack of valves in the dural sinus system allows follow through the emissary vein into and out of the cavernous sinus, and thrombus can propagate into the dural system. Also, communication between the right and the left cavernous sinus via intercavernous sinus, anterior and posterior to the sella, which allows the spread of thrombus and infection from one side to the other. That's why local compression and inflation of the cranial nerve can lead to several partial and complete cranial neuropathies, include diplopia. These local compression inflammation of the cranial nerve can lead to the several partial or complete cranial neuropathies, include diplopia from the partial or complete external ophthalmoplegia due to the compression of the sixth abducent nerve, third oculomotor nerve, fourth trochlear nerve, and limited eye abduction from the abducent palsy is most common early finding, even progressing to inability to move the eye in any direction when third, fourth, and sixth nerve are involved. Internal ophthalmoplegia, non-reactive people occur from the loss of sympathetic fiber from the short ciliary nerve, resulting in miosis, and or from loss of parasympathetic fiber from the cranial nerve 3, resulting in mydriasis. So it can happen both. Meiosis can happen and mydriasis can happen. In internal ophthalmoplegia, non-reactive people can happen because of the sympathetic fibers of the short ciliary nerve and causing the meiosis. On the opposite side, from the loss of parasympathetic fiber from the cranial nerve 3, resulting in the mydriasis. So we have to understand the cavernous sinus thrombosis. Numbness or paresthesia around the eye, nose and forehead, and loss of corneal blink reflex from the ophthalmic nerve, which is the branch of the trigeminal nerve. This numbness and paresthesia around the eye, nose, forehead, and loss of corneal blink reflex, all loss because of the ophthalmic nerve, which is the branch of the trigeminal nerve. Facial nerve paresthesia or numbness from the compression of the maxillary branch of the trigeminal nerve. Simultaneously, facial pain, paresthesia. Totally, patient behave like a trigeminal neuralgia because the effect is almost same. The maxillary involvement, the ophthalmic involvement. Septic cavernous sinus thrombosis can result in central nervous system or infectious pulmonary complication because the dural venous and cavernous system is valveless. It is valveless system, no protection at all. So the venous blood can communicate with the dural sinus and the cerebral and emissary vein, leading to the meningitis. So dural empyema or the brain abscess, the infection can spread via the jugular vein to the pulmonary vasculature, resulting in septic emboli or abscess, pneumonia or empyema. Stroke can occur following carotid artery narrowing, vasculitis, hemorrhagic infection following progression to the cortical venous thrombosis. Hypopituitarism can occur due to the ischemia or the direct spread of the infection. In the same manner, the history and the physical examination, patient with the cavernous sinus thrombosis most commonly complain of fever, headache, which is 50 to 90%, periorbital swelling, pain, vision change, such as the photophobia, diplopia, loss of vision, all can happen. Symptoms may be present at onset or progress subsequently, subcutaneously or subacutely over days. Usually it starts with one eye and then progress to the another eye. So the less common symptom may include rigors, stiff neck, facial numbness, confusion, seizures, stroke symptoms, or coma. All can come in the history. So it's a vast thing. Patient with the cavernous sinus thrombosis most commonly complain of the fever, headache, 50 to 90%, periorbital swelling, pain, vision change, photophobia, diplopia, loss of vision, progressive subacutely overdays symptoms. Usually it starts with one eye and then progress to the another eye. Less common symptoms such as the rigors, stiff neck, facial numbness, confusion, seizures, stroke symptoms, or coma. Physical examination. Vital signs may reveal fever, which is the picket fence pattern characteristic of septic thrombophlebitis, tachycardia, hypotension. These all are the physical examination finding of the cavernous sinus thrombosis. Neurological finding such as altered mentation, lethargy, or abandonment, or no, which is not usual. Seizures or stroke syndrome such as the hemiparesis. Eye findings are nearly universal 90%, and this include periorbital edema, initially unilateral but typically bilateral, lid erythema, chemosis, ptosis, proptosis due to impaired venous drainage of the orbit, restricted or painful eye movement, less commonly papillary edema, retinal hemorrhage, decreased visual acuity, 22%, which is considered high, decreased visual acuity, photophobia, diminished pupillary reflex, and pulsating conjunctivas. Blindness can result in the 8 to 15% of the people of the cavernous sinus thrombosis. Individually, a sixth cranial nerve neuropathy is the most common neuropathy, resulting in the partial ophthalmoplegia with limited eye abduction because of the abducent nerve. That's why not once the abducent nerve is paralyzed, then abduction, eye abduction has been stopped because of the partial ophthalmoplegia. Most cases, however, progress rapidly to complete external ophthalmoplegia from third, fourth, and the sixth cranial neuropathy. Internal ophthalmoplegia result in the non-reactive people from the paralysis of the iris and the ciliary body, either constricted meiosis from the loss of the sympathetic fiber from the short ciliary nerve and the dilated mydriz and the dilation of the pupil, or we can say mydrisis from the loss of the parasympathetic fibers of the third cranial nerve. Horner syndrome, ptosis, meiosis, and androsis may be present. It can present like this. Ptosis can be associated with the venous sinus thrombosis. The sensory exams might reveal diminished sensation to face due to the compression of the ophthalmic and maxillary branch of the fifth cranial nerve and an impaired corneal reflex. Evaluation. The optimal diagnostic test is neuroimaging with either contrast enhanced computed tomography or the magnetic resonance imaging. CT venogram or contrast enhanced magnetic or resonance venogram are highly sensitive, whereas non-contrast CT and the time of flight MRV may miss the diagnosis. Non-contrast CT of the head, although not ideal for the cavernous sinus thrombosis. Ophthalmic vein, bulging of the lateral margin of the cavernous sinus, exophthalmos, and possibly the presence of the sphenoid or ethmoid sinusitis or mass lesion near the sphenoid or the pituitary gland, all are involved. Contrast enhanced MRI brain shows bulging of the cavernous sinus, increased dural enhancement, and absent flow void is seen. This computerized tomograph venogram and the enhanced magnetic resonance venogram can detect dilatation of the cavernous sinus, enhancement and convexity of the lateral wall, which is normally concave on the corneal view. Heterogeneous and asymptomatic filling defect after contrast, increased density of the orbital fat. Thrombosis is in the superior ophthalmic vein or the vein and attribute lead to the cavernous sinus. Additionally, carotid artery narrowing, carotid arterial wall enhancement, cerebral infarct, intraparenchymal hemorrhage, empymas, meningitis, cerebritis, and the cerebral abscess may be noted in cavernous sinus thrombosis. Multiple thrombosis are common with this condition, and dural venous sinus and the cerebral vein are to be evaluated carefully. There is a chance that this cavernous sinus thrombosis may propagate to that veins also. Blood studies may reveal elevation in the white blood cells count and the C-reactive protein, erythrocyte sedimentation rate, and the D-dimer also have been raised. Blood culture should be obtained routinely and are frequently positive. Lumbar punctures is important to exclude meningitis and may show elevated opening pressure and pleocytosis even in culture negative sample. Screening for thrombophilia may give false result during anticoagulation therapy and should be delayed until after treatment is completed. So this is all are from the cavernous sinus thrombosis. Now I want to come to the important part of this lecture, which is called the treatment and the management. Because of the rarity of the diagnosis, no randomized controlled trial are available, and expert opinion guides treatment. In general, antimicrobial and antithrombotic therapy are the primary consideration. Antimicrobial therapy includes an anti-staphylococcal agent such as the vancomycin if methicillin resistance is high, or the nefusilin. A third-generation cephalosporins, metronidazole for anaerobic coverage, as well as antifungal therapy with amphotericin B is very, very important. A prolonged duration of the parental therapy, typically 3 or 4 weeks or at least 2 weeks beyond clinical resolution is suggested. Most experts recommend anticoagulation in the absence of the strong contraindication, which either in unfractionated heparin or low molecular weight heparin for the several weeks to several months, even though not supported by the prospective clinical trial in cavernous sinus thrombosis. Retrospective review suggested that the possible decrease in mortality from 40 to 14% with unfractionated and heparins, and reduction in the neurological morbidity also from 61 to 31% when anticoagulation is combined with the antibiotic for septic cavernous thrombosis. So there does remain controversy with anticoagulation. The advantage would be halt the progression of thrombosis, prevent clot propagation, and possible allow penetration of the antibiotic, whereas the risk would be systemic or intracranial bleeding or even dissemination of septic emboli. Although cavernous sinus thrombosis differ from the cerebral venous and sinus thrombosis, the coherence collaboration suggests that the anticoagulation for cerebral venous and sinus thrombosis appear safe even in the presence of intracranial hemorrhage and demonstrate potential important mortality reduction, though not statistically significant. The European Federation of Neurosurgical Society EFSNS recommend that 3 months of the anticoagulation in secondary cerebral venous sinus thrombosis with a transit factor should be important, and 6 to 12 months for the idiopathic cerebral venous and sinus thrombosis, and those with the mild thrombophilia, and indefinitely if subsequently cerebral venous and sinus thrombosis or the severe thrombophilia. So these are the seriousness about the use of the anticoagulation for this type of difficult problem. As in cerebral venous and sinus thrombosis, there is inadequate evidence to support thrombolysis in cavernous sinus thrombosis. Corticosteroids are often given but without demonstrated efficacy. The potential benefit would be decreased inflammation and vasogenic edema surrounding cranial nerve and orbital structure. Steroids are necessary, however, for the cases of the hypopituitarism, then steroid is very much judicious. International studies on the cerebral veins and the dural sinus thrombosis reported steroid use in 24% of cerebral thrombosis with no evidence of the improvement, but still people are using that. Because of the rarity of this problem, because the clinical trials couldn't happen for these kind of the patient, that's why what the knowledge we have, we cannot be uncertain or certain for few things. But the consensus over the use of the antibiotics and the anticoagulants. No surgical intervention are recommended for the cavernous sinus thrombosis up till now. However, some patients might require sphenoidectomy, ethmoidectomy, maxillary antrostomy, mastoidectomy, abscess drainage, craniotomy, craniotomy for the subdural empyema, craniotomy sometime needed for the large cerebral abscess, which is causing midline shift, or the orbital decompression or the ventricular shunt are very, very much indicated according to the given condition of the patient. The patient should be followed closely even after the discontinuation of the antibiotics. The differential diagnoses are very important regarding this. They include other causes of the cavernous sinus syndrome and painful ophthalmoplegia. Cavernous sinus syndrome can also be caused by local compression of the cavernous sinus from non-infectious and non-thrombotic lesions, 30% of which are tumors. Carotid cavernous fistula with enhanced CT or MRI showing proptosis, and large superior ophthalmic vein which is dirty, and appearance of the retroorbital fat and enlarged extraocular muscle are considered as a differential diagnosis. I am repeating: the carotid cavernous fistula with enhanced CT or MRI showing proptosis and large superior ophthalmic vein which is we can say dirty, appearance of the retroorbital fat and the large extraocular muscles. One more example, such as the lytic bone lesion near the sphenoid sinus or sella trachea tumors, such as metastatic cancer, meningiomas, schwannomas, plexiform neurofibroma, pituitary adenoma, chordoma, chondrosarcoma, melanocytoma, or we can say nasopharyngeal carcinoma. The most common primary malignant tumors are usually there. Or we can say the cavernous hemangioma also behave like this sometime. Meningiomas, sinus orbital aspergillosis, superior orbital fissure syndrome, Tolosa-Hunt syndrome involving of the retroorbital granulomatous pseudotumor into the cavernous sinus manifest a retroorbital pain, ophthalmoplegia, cranial nerve palsy, and the clinical response to the systemic steroid usually, and steroids are when even the people are using, but in cavernous sinus thrombosis steroid is still unclear. The use of steroid is very, very unclear up till now. Other causes of the painful ophthalmologic include such as orbital apex syndrome, inflammation of the posterior orbit, including the superior orbital fissure, through which the cranial nerve 3, 4, 5, and 6 and the superior ophthalmic vein traverse, as well as the optic canal involving the ophthalmic artery and the ophthalmic optic nerve, and characterized by the less edema and proptosis but more vision loss than the cavernous sinus thrombosis. So in that manner it is a message for us, the orbital apex syndrome, which is called the inflammation of the posterior orbit, including the superior orbital fissure, which carries lot of nerves, and a 3, 4, 5 and the 6, and then superior ophthalmic vein traverse from that, and as well as the optic canal involving that in the ophthalmic artery of the, but this is very serious because the vision loss is more in the orbital apex syndrome as compared to the cavernous sinus thrombosis. Orbital cellulitis is also a differential diagnosis, sarcoidosis, syphilis, and tuberculosis. Here, how we enhance the outcome of these kind of patients. Cavernous sinus thrombosis, as we know, is a rare but life-threatening disorder that can complicate facial infection, sinusitis, orbital cellulitis, pharyngitis, otitis, and following traumatic injury or surgery, especially in the setting of the thrombophilic disorder, either the minor thrombophilia or the major or the severe thrombophilia. The disorder is best managed by an interprofessional team that include the primary care provider such as the nurse practitioner, physician assistant, family physician, ophthalmologist, neurosurgeon, neurologist, infectious disease expert, hematologist, and emergency department physician. Early recognition of the cavernous sinus thrombosis, which often present with the fever, headache, and eye finding such as periorbital swelling and ophthalmoplegia, is critical for the good outcome. Despite modern treatment with antibiotics and anticoagulation, the risk of the long-term sequelae such as vision, diplopia, and strokes remains significant. As many as 50% of the survivor might have sequelae, most commonly third or the sixth nerve supply. Other complications can include sepsis, meningitis, subdural empyema, brain abscess, blindness, panhypopituitarism, intracranial hypertension, infectious arteritis, or mycotic aneurysm of the internal carotid artery, vasospasm, septic emboli, strokes from the carotid narrowing, critical vein thrombosis, or hemorrhagic infarction, coma, and the death. So as many as 50% of the survivor might have the sequelae. So most commonly third and the sixth nerve palsy. Third or sixth nerve palsy is major issue in 50% of the way. Other complication, as I mentioned before, sepsis, meningitis, subdural empyema, brain abscess, blindness, panhypopituitarism, intracranial hypertension, infectious arteritis, or mycotic aneurysm of the internal carotid artery, vasospasm, septic emboli, stroke from the carotid narrowing, and the cortical vein thrombosis, or the hemorrhagic infarction, coma, and death. Mortality rate are high, and 80% of the era before antibiotic have diminished to below 8% to 13%. So As we are considering that it's a very serious issue and we have to take it very seriously, we have to diagnose appropriately, we have to manage properly, and we have to get the better outcome for, and make it clear this unfractionated heparin may use for the long time. Thank you so much. I tried from my side. Such a difficult topic to manage it. It really, believe me, it's not easy to manage, but I tried to some extent. Thank you. I hope you will like it and subscribe me and share this. Thank you so much.